Cristina Sánchez, one of the most important cannabis researchers in the world. She is in molecular biology in the Complutense University of Madrid, and she's going to talk about cannabinoids as antitumoral therapy. So, Dr. Sanchez, you have the floor. So, in this half hour, I'm going to try to summarize briefly about the clinical evidence that suggests cannabinoids can be used for the treatment of cancer. As you know, cancer is a pathology that is uncontrolled growth of mutated cells, and this is usually accompanied by the generation of new blood vessels that will irrigate these growing tumor masses, providing them with nutrients, eliminating waste, and in the more lethal or advanced stages of the disease, we see what is called metastasis, which is colonization of new niches in the body, forming new tumor masses. And in addition to this, patients have to deal with pain associated to the disease and side effects of the anti-tumor therapies they receive. Among them, we have mentioned loss of appetite, nausea, vomiting, of course, pain, toxicity in important organs. And for years, we've known that cannabinoids can benefit cancer patients as palliative agents. In many countries, for example, they can be prescribed to treat cancer pain or symptoms associated to anti-tumor therapy. But what our group has been doing for over 15 years, trying to show that in addition to the palliative effects, cannabinoids can have anti-tumor effects. In other words, they could fight tumors. Well, when you want to show that you have an anti-tumor tool, you have to show two things, and just two things. First, that it works, that it kills tumor cells and prevents the progression I showed you before. And secondly, they have to be safe. Very simple, but at the same time very complicated. And what I want to tell you is to convince you that we have preclinical evidence that is quite solid, showing that cannabinoids do meet these two requisites. Entonces, primero, do cannabinoids work as anti-tumor agents? Well, let's go for a bit of history, and then let me tell you how our group started with this type of studies. And from the end of the 1990s, we were working in the analysis of cannabinoid effect on the metabolism of brain cells, analyzing if when these cells are exposed to cannabinoids, they consume more or less glucose and lipids, etc. And we were using cells that were not neurons, but we're talking about the accompanying cells called the astrocytes. So we would grow them in petri dishes, expose them to cannabinoids, and do this metabolic analysis I was talking about. But working with astrocytes is very complicated, very expensive, very cumbersome and laborious, and it took weeks for certain experiments. So we needed a cheaper cell model and a more or a less complicated model. So basically we were looking at tumor cells because they do have the advantage of growing beyond control, and you can buy cells like astrocytes. So it would be the tumor equivalent of an astrocyte. And we started working with that. Well, we tried to do our metabolic experiments, but we couldn't do a single one because when we exposed the tumor cell to a cannabinoid, the cell died. This time I was starting my PhD thesis, and I was in a crisis. I was like, okay, they're going to kick me out of the laboratory. I cannot do a single experiment. But after a little mental block, we realized that we had something that was killing tumor cells. So we left aside all our metabolic studies and started focusing on this potential anti-tumor activity. So the first thing we did was to confirm that it was indeed the case, and effectively what we observed time and time again, is that our tumor astrocytes, when exposed to THC, the cells died. And that is the aspect of a tumor cell culture in a petri dish, and that's the aspect after being exposed to THC. So you see that the cells are unclumped and dead. And we see here that in cell lines and others, we see that this effect would not happen in the astrocyted cell, the healthy cell. They did not respond to cannabinoids in this way. They would not die when exposed to cannabinoids, as tumor cells did. So when we realized that it was the answer in cell culture, we went a step ahead and started analyzing this potential anti-tumor effect in different animal models for cancer. On the left, you have the simplest one, where you inoculate tumor cells, human tumor cells, in the back of immunodeficient mice. So you have brain tumor cells that you inject into the back of a mice that has been bred to have no immune ability. So here you have the effects of an animal receiving THC and not receiving THC. You see that the tumors of the group receiving THC are much smaller and that are not as red. So we are blocking not only the growth of the tumor, but the other process that it is and the genesis of blood vessels for irrigation and elimination purposes. But you see that this model on the left has limited physiological relevance. We are generating a brain tumor in the back of a mouse. So we wanted for a more physiological model, so we generated brain tumors in the brain of rats. To the left, we have an MRI of a rat before receiving THC treatment, and you see this white mass there? That's a brain tumor. To the right, you have the same rat after THC treatment, and you see that the tumor is gone. And this white spot is the scar of the injection of THC into the tumor, but the tumor itself has completely disappeared. After many years of work, we know very well what happens inside the tumor cell that makes it disappear. We know that cannabinoids activate specific receptors, as we've said before, CB1 and CB2, activate a cascade of events within the tumor cell, and I'm not going to bore you with the details. And what I want you to have clear is that all this information results in the inhibition of this protein, which is the key regulator of cell survival, whether it decides whether it is alive or not. We have shown that when cannabinoid receptors activate, this regulator protein is inhibited, so this activates what is called apoptosis, or the suicide of the tumor cell. So apoptosis is the scientific way to call cell suicide. So this slide summarizes 10 years of work, coordinated mainly by my colleague Guillermo Velasquez. So that's for brain tumors. For a few years, however, we've opened a second line of research, which is breast cancer, particularly a type of breast cancers that have high levels of this protein called ER2. Currently, these patients are treated with a specific antibody, anti-ER2, which is called trastuzumab. And even trastuzumab has improved the prognosis of these patients. There are still some patients who do not respond or who initially respond but then acquire resistance to the drug. So we wanted to continue with this because the treatment for these patients is not finished then, and we want to know whether cannabinoids could be useful. So in these experiments, we used a very interesting animal model, which is MMTUV new mice, which are genetically bred to express this new protein, which is a rat equivalent to ER2. As a consequence of this genetic manipulation, these mice spontaneously generate breast tumors. We don't have to inject it into them. And they do it with a very, very long latency period, which mimics the human pathology because we don't have rapidly appearing tumors here in our patients. Another characteristic of this model is that about 80% of the female mice generate metastasis to the lung. So because of this characteristics, this model is considered in the clinical community as a very good breast tumor model or positive for ER2 metastatic. ER2 positive is called. So we treated these patients or mice with THC for 3 months. And this is the behavior of the mice or the female mice to which THC was not administered. And we see the size of the tumors over time. And you can see that the tumor growth is even exponential. But when they were treated with THC, this growth is significantly decreased. And not only that, we also observed that THC reduced the generation of tumors. I don't know whether you know it, but female mice has 10 nipples or 10 breasts, if you will. So we found animals with multiple tumors. And in the population that does not receive THC, we observed a 40% of individuals with 4 or more tumors. If you compare that with the THC treated population, we did not find any with those characteristics, and 50% only had a single tumor. So we're reducing not only size, but number of tumors. THC also decreased the percentage of animals developing lung metastasis, which is represented here in this bar. But these data come from an animal model. So the next question is, will a human breast tumor cell, would it be susceptible to cannabinoid treatment as well? So we started culturing cells with ER2 positive cells, human breast cells that were cultured, exposed to THC. Then you can see the green bars. As the THC concentration increases, their viability is decreased. In other words, we kill them with THC. We can reproduce this behavior in vivo in animal models. In this case, we went back to the tumor generation model. In other words, injecting tumor cells in the backs of immunodeficient mice and then treated the individuals with THC. It was oral administration. We wanted to basically simulate as close as possible what the route would be for human beings, administration route. And here in white you have the behavior of the population does not receive THC. And you see that the ones that do receive it have decreased tumor growth. We also analyzed whether, in the case of glioblastomas or brain tumors, the mechanism went through the apoptosis or cell suicide of the tumor. And it was the case. I'm going to show you a couple of examples. In this case, we are marking or dyeing the cells that are proliferating within the tumor, and we can mark them with a pink dye. I don't know whether you see it, but in this photograph to the left you have a lot of pink little dots, an animal that has not received THC, and to the right we have a lot fewer dots. In other words, that tumor of the animal that received THC went down in size. And this is also inducing apoptosis or the suicide of tumor cells. And I don't see whether you can see it because I don't either, but in this photograph for the animal treated with THC, we have a lot more pink dots compared to the animal that did not receive it. And right now, we are marking then or dyeing the cells committing suicide. And THC treatment also reduced the number of blood vessels irrigating the tumor. Again, we are seeing that angiogenesis is being blocked by THC, in other words, the formation of new blood vessels. And as you can see, we've seen about 1% of all the results that we have so far, not only from our group, but many other research groups that are working on THC, especially as an antitumoral agent. I hope I convince you that there is potential, and even the models on which we can work show that cannabinoids have an enormous potential as anti-tumor agents. Now, the second question is whether they are safe. And they are. I'm not going to show you too much data, but we already know that this response of cell suicide is not induced in non-tumor cells, in other words, in healthy cells. You work with an astrocyte and expose it to HC, the astrocyte will not die, but an astrocytoma or the tumor equivalent will. We've shown it all other types of tumors we have worked with. And we have additional evidence that show or suggest that cannabinoids are safe compounds. The first one that I want to show you is that at least in breast cancer, anti-tumor effect is due to activation of the CB2 receptor. Remember from the presentation that we have CB1 and CB2. They're responsible for the psychotropic effects of marijuana is CB1, which is abundantly expressed in the central nervous system, but it does not have CB2, and it's very, very low. So the psychoactive effect of marijuana is due to the activation of CB1. And you see that the most of the beneficial effects here are due to the activation of the non-psychotropic receptor. So you see that the anti-tumor effect that we observe in the spontaneous breast cancer model shows that the THC effect is produced as J2LH, which is a synthetic cannabinoid which only targets CB2 as a receptor. So in other words, we can reproduce THC's effect by activating CB2. And in this other graphic, what we've seen is, or we've done really, is to block CB2, not allowing that THC activate CB2. So it's an antagonist, basically. We treat animals with THC, and one of these lines we have the animals that do not receive it, and when we treat with THC we have an anti-tumor effect, and when we block CB2 with this SRO2 we lose the anti-tumor effect. In other words, CB2 needs to be activated to have an anti-tumor effect. showing again that the activation of the non-psychotropic receptor produces the anti-tumor effect. So now the question is, do we have CB2 in patient tumors? Because this data came from animals. Well, what we've done recently to answer this question is to analyze the expression of this receptor in over 700 patient samples. This is a rather complicated chart. Don't waste your time. Just look at this. But here are 2 positive patients. And this sample collection was to analyze the expression of CB2 and give it a classification or category. 0 would be no receptor. 3, if you had very high expression of CB2, and intermediate, you would have 1 or 2 with a bit or a bit more of CB2 expression. And we started analyzing our almost 800 samples and showed that here 2 positive patients, only 3% of them did not have any of these receptors. In other words, 97% of the patients, basically everybody, have at least some CB2 receptor. So if we're talking about cannabinoid-based therapies, these patients would have the target on which we're acting.
Another argument to defend that cannabinoids or cannabinoid therapies can be effective and safe in treatment of cancer, in this case breast cancer, is that CBT, the cannabinoid, as we said, is a non-psychoactive cannabinoid produced by marijuana, produces exactly the same anti-tumor effect as THC, at least in our models for HER2-positive breast cancer. The white and green bars you've seen before already, and in this case, let's look at the yellow ones, which correspond to CBD. Just as THC, they are reducing, based on dosage, the feasibility of tumor cells. And they do this not just in vitro, in cell cultures, but also in animal models. This is the behavior, if you remember, of the animals that did not receive cannabinoids. This line is growth in tumors on animals that are treated with THC, and this is the behavior of tumors for those that are receiving treatment with CBD. These are the preclinical data we have that say that cannabinoids are safe, but there's many data that say that they are safe in humans. These data come from several clinical trials that have already been performed throughout the world, not just on oncological patients, but also those that have pain, anxiety, and different pathologies. 1 day before I came, I searched to find how many clinical trials have been performed to date with 3 cannabinoid medications, Sativex, Marinol, and CBD. And for Sativex, there's 318 trials that have been completed. And all these show that cannabinoids are safe. Sativex is safe. There's 86 trials, completed trials with Marinol. Each and every one of them says that Marinol is a safe compound for patients. And there's 39 on CBD, and those all say the same as well. This means that cannabinoids are safe compounds for patients. So, we have compounds that work as antitumoral drugs, and they are also safe. What should we do now? What comes next is finding out if they actually work on humans for antitumoral agent effects. For this, the only option we have is to test them on humans. Our group participated in a pilot trial that was done in 2006. It was the first in the world where oncological patients received a treatment with THC. Not to see if it helped with the side effects of chemotherapy, but actually to see if it had anti-tumor effects. This trial was done in 2006 in Spain. It was a pilot test because we could just have a very small number of patients, specifically 9, and patients that had a very advanced stage of the disease with recurrent multiform myoblastomas and that had been already dismissed for the rest of the treatment. And so we worked with patients that had been diagnosed with GBM that had already gone through a first surgery to eliminate the tumor, along with radiotherapy and chemotherapy, and months later the patients had recurrence. When starting to come to the second surgery to remove the recurrent tumor, they had in the exact place where the tumor had been taken out of a catheter dispensing THC directly in the brain. And we followed these patients until their death. What we observed, and before telling you the results, I would like to insist that the population under study was very small, so the conclusions can be just limited. But of course they show us the direction that could be very interesting. First of all, THC, I insist, it was directly injected into the brain. It did not lead to any psychotropic effects. Secondly, we saw that it reduced tumor growth in some of the patients. THC also increased the life of some of the patients. And these two things, reduced tumor size and more life, or increase in life, were done by THC just as well or as bad as thermoformide, which is the medication that these patients currently receive. So THC was just as effective or as ineffective as the only medication that they can receive right now. And something that for us is very important is that we observed that THC activated the same molecular mechanisms that in our animal models. This validates the potentiality and the relevance of preclinical models that we are using in the lab. If we look at the colored spots, what you have to the right in each of these panels is a sample of a tumor of a patient after receiving THC treatment. And I could say you could see, but I'm not sure. You have to believe me. I'm not sure if you can actually see it. But in this case, we saw less cells proliferating in patients that were treated with THC, less blood vessels irrigating tumors, and many more cells with apoptosis. This trial was done in 2006, as I said, and in these almost 10 years, as has been mentioned previously, there has been a stop or a block to this. We don't know why. We intuit, but they're not politically correct, so I cannot go into them. But thankfully, in 2014, we had a trial, a study that began in the UK, and it will analyze the effect of a combination of Sativex with thermosolamide, which is the standard treatment for GBM patients. The screening for these patients has already started. They have to have multiform glioblastoma, and we hope to have results by the end of this year or during 2016. A bit later after that, there was a clinical study that started in Israel that will treat patients with solid tumors without differentiating the type of tumors, in this case with CBD. It won't be combined with any other medications. It'll be applied as a single agent. In principle, they will start recruiting patients in November last year, but as far as I know, it hasn't started. So these results will take a bit longer. But the good news is that at least we have 2 studies underway, and in the coming months, possibly 1 or 2 more. To conclude, we firmly believe that we have solid evidence to say that cannabinoids could be a new therapeutic tool to treat cancer because they work as anti-tumor agents, at least in the preclinical models, and because they are safe. Also, we have mentioned that cannabinoids have additional advantages that benefit oncological patients. These are analgesic compounds, they stimulate appetite, they are antiemetics, etc. So what can we do on our part to continue promoting, and what will we do to promote the fact that cannabinoids have to come to clinical parts for the patients with cancer? We are still doing our research. That's what we do. That's our part. And we're still seeing now whether cannabinoids combine well with standard treatment that patients receive currently. We also want to know more about the mechanism of action in biochemistry. Like in life, information is power. The more you know and the more information you have on the action mechanism of cannabinoids, the best and the most refined manner will you find to fight the tumor cell. We are also aware that to know these work on humans, we need more trials on humans. And for that, we do a lot of informing and telling things to anyone that wants to listen to us. Of course, it's not just the scientific community. They're already convinced. Now we have to go to the clinical community. These compounds have to reach patients as soon as possible. We know they're already using them, but they're using them in the way that might not be the best way. So we want to convince the medical community that patients have to benefit from these treatments and as soon as possible. To end, I'd like to show you all the people that are involved. There's many more that have gone through our lab in all these years. This is just a small representation of the people that participates in our studies for glioblastomas and breast cancer tumors. And I'd like to especially thank those that work on breast cancer, because I coordinate this area, and you can see them here in the picture. Very especially Eduardo Perez Gomez, who is a postdoctorate fellow that basically is in charge of the lab, Clara Andrada, Sandra Vasco Benito, Rodrigo Hernando, and Manuel Guzman, that I'm sure many of you know. And with that, thank you very much for your attention.